So we're going to get moving forward with the exciting information today, which is CVA. This is a lot of information, but I think it's extremely exciting. In my opinion, I get very excited about these things. So everybody had a chance to hopefully look over the PowerPoint so you're not starting from just, this is the first time you're hearing this stuff. Today, what we're going to cover is recognizing the large prevalence and incidence of CVA, the modifiable and non-modifiable risk factors, also this behavioral, social, environmental factors that can contribute to the risk. Describing body's normal response to CVA, warning signs of a stroke. What do you do if a patient's having stroke in front of you? I'll tell you some examples of things that I've had to do with patients who've had strokes in front of me. Practicing patient education on stroke signs and explaining why time is of the essence and it's so significant for recovery. We'll differentiate between hemorrhagic bleeding strokes and ischemic blockage strokes, and recognizing signs and symptoms of increased cranial pressure and identifying what your response should be. Identifying medical, surgical, and pharmacological interventions for these patients and differentiating the medical treatments based on the stroke. So if somebody's bleeding, they're not going to get a blood thinner as an intervention, right? That would make it worse. So we're going to talk about what the differences in treatment are for these individuals. We'll talk about pharmacological. I found the best way to do this is by applying to a specific stroke. Describing the circulation of the brain. Okay, Circle of Willis, one of my favorite things. And then identifying common locations of lesions. We're going to correlate that with the cerebral anatomy and also talk about the phases of healing, describing and explaining causes and symptoms of CVA, recognizing implications of CVA on central nervous system, describing possible activity limitations, and that's quite a lot of objectives, right? So let's start from the beginning. What is a CVA? Okay, this is a sudden loss of neurological function caused by an interruption of blood flow. Can either be by a blockage or by excessive bleeding. Which do you think happens more often? Ischemic strokes, very good. So blockages definitely happen more often, although hemorrhagic strokes do happen. They tend to be more life-threatening than ischemic strokes, because what happens with ischemic strokes for treatment, there's a blockage, they can free up that blockage with what? Medication. What do you do if there's bleeding, excessive bleeding? There's no medication to try to make it block. So oftentimes these patients are undergoing surgery. Okay. Yeah, surgery. Exactly. Thank you. Very different reasons. We'll talk about the causes here. Epidemiology. So this is a consequence of cardiovascular disease. We talked extensively about cardiovascular disease last mod and all these risk factors for cardiovascular disease. This is why it's so important that if we have a patient who has cardiovascular disease, we're discussing it with them, whether we're treating them for Achilles tendonitis or we're treating them for hypertension. We are talking about cardiovascular disease with all of our patients because prevention is key. And we do not want any of our patients having strokes. This can be extremely life-threatening and life-changing. Okay. Deaths due to CVA, coronary heart disease, 43.8. Strokes, 16.8, blood pressure, 9.4, heart failure, 9%, and then diseases of arteries. This is really a very common disability for adults in the US, and stroke ranks number 5 among all causes of death. And it's killing 133,000 people a year, which can be preventable, right? That's what's so maddening about this. A lot of it is very much lifestyle, and that's where we can come in and really try to educate patients, because a lot of them just don't know. They don't know that what they're eating can be bad for them. They don't know that sitting down all day long and having a desk job can be detrimental to their heart, even though they should. But that's our focus, right? We're all about health and wellness. A lot of people just don't know. Just some more statistics here. Higher risk for African Americans, Mexican Americans, American Indians, and Alaskan Natives. Knowing your demographics and talking to patients about this. And then incidence really doubles after 65. The older that we get, we are at risk because of our age. Okay? There are some strokes that occur before someone's 65. These are rare. However, they can happen. I treated an individual who was on birth control. She didn't know that smoking and taking birth control put her at a high risk, and she had a stroke at 22 years old, and it was a very severe stroke. So she had significant drop foot. She hated her AFO. She just hated life, really. And it was very depressing for her. And we worked through it, but very life changing. And so just talking to individuals about this as well. Now, more likely hemorrhagic if it's a young stroke. Strokes can happen in children. So this is why we cover this now, and we'll talk about pediatrics. Sometimes babies can have strokes in utero or during birth. Also, higher risk are people who have blood disorders, sickle cell disease or congenital heart disease, where there's more likelihood of formation of clots, right? And I think that's really all I wanted to say about that. What are some major risk factors that you know for CVA? What do you think are some major risk factors? Diet, for sure. Smoking, for sure. DVTs, yep. DVTs can travel. Hypertension, for sure. Lifestyle, for sure. Obesity, yes. Okay, these are all great ones. Okay, very good. Atherosclerosis, hypertension, heart disease. If someone has hardening in their blood vessel and they have high blood pressure and that vessel can't accommodate to that pressure, what happens? They can get an aneurysm, or even worse, it can just blow up. And that's a hemorrhagic stroke. I had a woman on my street who I would see every morning when I walk my dog exercising in her garage. She was the epitome of health, in my opinion. She looked great. She was 74, very active. She couldn't control, her blood pressure was not controlled. It was a Tuesday, and she all of a sudden couldn't talk anymore. Her husband said they had to rush her to the hospital. That Friday, she had an appointment with her cardiologist about just changing her medication. She was dead by Thursday. Insanity. Very sad. So it's really important to try to control blood pressure. Now, blood pressure can be hereditary, but very much we can try to control our blood pressure in a lot of different ways. Diet specifically, activity, obviously. Okay. People who have diabetes, we know that they are more susceptible to heart conditions because of that hardening, right? So those are the people that are really at high risk for hemorrhagic strokes. And then smoking, obviously. And actually, I watched a video recently about how smoking is really detrimental to our blood vessels, but what they're finding is actually diabetes and hypertension, and atherosclerosis is even more detrimental. Not that smoking's good, but diabetes and hypertension, just having that is actually much more exponentially more dangerous. And then TIA, which we're going to talk about in a little bit. Does anybody know what a transient ischemic attack is?
The mini stroke that can just happen and then happen again because it keeps traveling through the blood.
So it's all the warning signs that a stroke is happening or is going to happen. So a person can present just like they're having a stroke, a mini stroke, and it goes away within 24 hours. That's the key. So patient recovers. But this is a warning sign. We better get some things in order because your body's telling you you're about to have a massive stroke, and those issues can stay. Secondary risk factors: obesity, hypercholesterol, high cholesterol, physical inactivity, and alcohol consumption. What should be in here too is drug use. I treated a young man in his 30s right after New Year's. His wife was pretty pissed at him, and I read his chart and understood why. He was partying on New Year's and did a lot of cocaine, and he ended up giving himself a stroke, and he fell down the staircase and broke his arm, and he had a hemorrhagic stroke. So he's lucky that he's even alive. Definitely alcohol consumption long-term can be an issue, but even short-term combined with drug use can be a major issue, can be a major risk factor. Let's keep going. I'll tell you about other patients later, but just trying to give you some painted pictures in your head of these patients. This is a printout from the American Stroke Association. I do give this to my patients in home care. There are some from the Heart Association as well about high blood pressure, and that kind of have the same thing here too. Education is key. Remember, there's all types of learners out there. Sometimes checklists are nice. Sometimes visuals. Patients who are older like to read a lot. Sometimes giving them different handouts are sometimes really nice. Education. Definitions, you will hear stroke and CVA used interchangeably. These are the same thing. Now, the TIA, the key is 24 hours. If you're presented with a question that says that the patient lost their ability to speak, but recovered within 24 hours, that's a TIA. If the patient lost their ability to speak, but they recovered in 1 week, is that a stroke or a TIA? It's a stroke. Yeah, it's a stroke, even though they recovered. Okay, so keep that in mind. A TIA means that they recovered within 24 hours. But we hope that our patients all recover, whether it's 1 week or 3 years, we hope that they make recoveries, okay? But that's still, if it's more than 24 hours, it's going to be considered a stroke. These are warning signs that an individual is having a stroke, so it can present in many different ways. So we'll talk about, these are the warning signs. One side of the face, and this will make more sense as we talk about the lobes of the brain. Again, we review those, and as we talk about the circle of Willis and distribution of blood. So individuals, sudden onset, that's the key. These are sudden onsets of numbness, weakness, face, arm, leg, one side of the body, okay? Trouble with speaking or understanding speech. So inability to speak is expressive aphasia. The person has a hard time expressing what they want to say. Receptive is receiving information, so understanding what is being told to them. A patient can present with both or one or the other. Trouble seeing in one or both eyes, trouble walking, dizziness, balance coordination, sudden severe headache. Honestly, if any of these are happening, you just call 911 because you don't know if they're having a stroke. It's not up to you to diagnose, but it's up to you to recognize these are not typical signs and call 911. I worked with an individual on a boat in home care, very unique type of individual. I think anybody that lives on a boat full time is a unique individual probably. She was a little kind of odd. She would say funny things. So I only treated her 2 times and I went to see her for our 3rd visit. And she was acting a little funny, but nothing super crazy to catch me off guard. But I went to have her sign her name at the end of our treatment. She couldn't sign her name. What do? Leave her and hurry up to get to my next client because they're in 15 minutes down the street? Or do I have to stay with her and call 911? I had to stay with her and call 911. I called the next patient and let them know, okay, I'm with a patient, there's an emergency. I'm probably going to run late. I'll let you know when I'm on my way. And if it doesn't work out, we'll reschedule. That's how you handle the situation because that patient you're with is critical. And I didn't know what was happening, but I knew something wrong was happening. And it ended up, her spouse called me later that she was having a stroke. It can present very obvious, and then sometimes it's not so obvious. But talking to our patients, a lot of times you hear patients say, yeah, I was having trouble and I just decided to take a nap. It's very common. So if we're treating individuals that we know have these uncontrolled high blood pressure or have a lot of these warning signs, we want to make sure that they're familiar with these warning signs of stroke and that time is of the essence. Okay, here's another just slide showing an accurate acronym to help individuals understand that it's really critical because within 3 hours of symptoms, they can get treated and maybe restore that blood flow and prevent damage in that area that's lacking blood flow. And then there's another one for you. So these are all really nice. These can all be printouts that we can give patients. Let's talk a little bit about the different type of strokes, a little more in depth here. Okay, so we have our blockage stroke, our ischemic stroke, and our rupture. Okay. So ischemic is really about 90% of CVAs. This is very common type of stroke. So patients end up having a thrombus. A thrombus is a collection of the blood clots or a clot of any kind. This could be fat clot, something that's going to block that blood flow. Embolism is that traveling blood clot. Now, we're going to talk about blood flow here in a little bit. And DVT, somebody said DVT. DVT, where do we usually see them come up? What's so dangerous about a movable DVT or dislodging a DVT? Where is it going to go? Pulmonary lungs, yeah. This is where it comes in important to understand your blood flow. Actually, blood clots typically come from the side of the heart that's blood's leaving, right? The left side of the heart. And we'll talk about that here in a second. Now, mortality rate here, 8 to 12% mortality 1 month, where it really is all dependent on how long were they out of that blood flow, how big of an area was affected in their brain, what is the function in that area. Do you think it's more detrimental if they had lack of blood flow to this part of their brain? Okay, to orient you, this could be the frontal lobe or in the brain. Which one do you think is more detrimental? This area or the brainstem? Both probably detrimental with the brainstem, right? What's located there? Our respiratory center, cardiac center, right? Okay, so really we'll talk about these little divisions and what's responsible in that area and why people present differently. The other thing that's mentioned here is collateral blood flow. Now, blood flow, there's a lot of overlap. We may have blockage in one area, but another area, there's actually could be a little bit of overlap, which is nice. That's called collateral blood flow, where there's some blood flow, but it's not the prime source, okay? But there's certain areas of the brain where there is only one prime source. So if it's lacking blood flow, it's going to be really bad for an extended period of time. Now, when it comes to hemorrhagic strokes, we talked about a couple different reasons for hemorrhagic stroke, but basically there's a rupture in the blood vessels. People who are really at risk are patients who have aneurysms, and some patients who have aneurysms that run in their family, they can get screened, but oftentimes aneurysms are a sign. People don't really realize that they have them. There's also can be these malformations between the arteries and the veins, the atriovenous malformations. Okay, so this can actually increase their risk for strokes as well, hemorrhagic strokes specifically. Now look at the mortality rate. Instead of 8 to 12, it's 37 to 38. So a lot of patients die within 1 month. Pathophys, just to continue with this, here, neurons without blood supply are going to die, and they die within minutes. Okay, so it's really important that the sooner that we can get treatment, the better. When cells are when we're lacking cells, then we're going to be lacking energy, and that can cause also just diffuse impairments. Also, ischemia can cause a rapid cascade of inflammation and swelling. So there's swelling that occurs, which can create increased cranial pressure. Underneath our bone here, our skull, is a couple layers, okay? Our dura mater, our arachnoid mater, our pia mater, then our brain, okay? If our brain is swollen, is there a lot of expansion in our skull? No. So it's going to press, and that pressing can cause damage too. So there's really not a lot for the brain to expand to, and that can have a lot of negative consequences. So are you familiar with any symptoms of increased cranial pressure? So there's swelling within the brain. How would a patient present if they have swelling in their brain?
Speaking.
Yeah, definitely. Headache. Yep. Increased heart rate. Yep.
Headache.
What'd you say, Ricardo?
A big headache.
Yep, huge headache. Huge headache. Increased is here, pressure. What do you think happens to the blood pressure? Could get maybe vertigo, maybe dizziness, yeah, depending on the area. They're going to have increased heart rate, increased blood pressure, okay? Decreased level of consciousness. Memory loss is typically long. That's not usually right away. Can shows vomiting, yes. Consciousness, very good. Visual disturbances, headache. They'll say burst and worse. Your brain is getting pushed inside your skull. That's going to hurt, right? So very good. Medical diagnoses. So time is of the essence. Patient's going to say worst headache of my life. Variable, it's uneven onset. That could be a thrombus, because maybe some blood flow is getting through and it's slowly turning on. But typically, first you hear the worst headache of my life is typically the standout signs. So history, patients maybe have previous TIAs, maybe they've had head trauma, cardiovascular disease, but the diagnosis is through imaging. So imaging, we have our CAT scans, we have our MRIs. When you're looking at any image, I know some of you are probably a little intimidated by these pictures, but how you want to orient yourself. This is not up to you to diagnose anything, but it's for you to get a respect for what's happening. So whenever you're looking at the brain at MRI or CAT scan, you want to orient yourself to what is midline. We have our ventricles here. What's happening here? All this swelling is pushing, shifting that midline. That's called a midline shift, and it's closing down on these ventricles. What's in the ventricles is cerebrospinal fluid. So it's compressing the brain. Not good. Okay. In the MRI, you can see some highlighted area that can show that there's some issue with blood flow there. But always orient yourself to where is midline and is it uniform. So CAT scans can be used right away, but within 3 to 5 days, where MRIs are great because they can show you that there's been an ischemia in 30 minutes, but pretty expensive. Dopplers, we've talked about Dopplers in previous classes. Sometimes patients will get Dopplers to see how is the blood flow to their brain, through those carotid arteries. Carotid arteries supply the brain with blood flow, and you'll hear somebody say, yeah, I have 70% blockage in my carotid artery. Good. And what is it being blocked by? Probably fatty buildup. These patients can opt to have what we call, layman's terms, Roto-Rooter. They can have that cleared out, but they run the risk of a little piece of that fatty tissue moving and causing a clot itself. Some patients will do that because that's less of a risk of just leaving it. So Dopplers usually are used to identify blood clots in the lower extremities, but it can just identify how good blood flow is going through and supplying the brain. MRAs, this just gives you a nice picture of all of the arteries of the brain. So this can help identify, is there an aneurysm occurring? It gives a very nice visual picture of the blood flow of the brain. Very expensive, non-invasive. When my husband went through that thing with his trigeminal nerve, they did an MRA because they had no idea what was happening. But our medical management, our goal here, control blood pressure, restore that blood flow, maintain glucose levels, keep that diabetes in check, maintain fluid, okay, electrolyte balance, and then maintaining all functions, okay, bladder functions, integrity of the skin and joints. Because if someone has a stroke, maybe they can't move. What's the risk? Pressure sores, all of the things, okay? Nosocomial infections from being in the hospital, not moving around, pneumonia. So all of these things we're worried about. UTIs, if they're not going to the bathroom or if they're urinating within. And then surgery, there's tons of surgeries, typically for hemorrhagic strokes, okay? They go in and they can either fix that AV malformation if it's ruptured, but these are really, this is the last resort, is brain surgery. We're gonna talk about pharmacological interventions with our specific cases to help it make more sense. I think just talking through medications is not very exciting, and you're not going to really be able to grasp onto the concept. So I'm going to scoop past these so we can get back into reviewing the brain lobes, okay? But we'll talk about main topics of the medications and where you really want to break up the word to help identify what the purpose of the medication is. So we're going to just slip past these because, again, we're going to go over them when we're in our cases. Now, I changed the order of this because I actually had a review class last Wednesday, and how I think it's best to dissect this week and ingest it is really first understanding the basics of the brain. Where are your lobes? What is contained in that lobe? What's the function of that lobe? Then going and looking at the homunculus, and if that word isn't coming to you didn't review, we'll talk about it, but you should have reviewed what the homunculus is. So we'll talk about that. And then lastly, we'll talk about the blood flow so that it all makes sense. Oh, the anterior artery goes here. That makes sense that it would be affecting the lower extremities, okay? So we're gonna get into that. So frontal lobe, anybody remember what the main focus of that frontal lobe is? How we remember this lobe? What did we say last week? Yeah.
Decision making.
Yeah, decision making, okay, personality. What else is located here that's really important in front of the central sulcus? cortex and Broca's area, only on the left side. Only on the left side is Broca's area and Wernicke's area, which is in the temporal lobe. Broca's area is about expressing yourself. How I always remember this is thinking about somebody who talked too much. They had a name that started with B. That's just how I remembered it. I won't say the name because I don't want to label any names, but that's how I remembered it. B is Broca's area, and it's if there's damage there, the person's going to have expressive aphasia. They're going to have difficulty saying what they want to say, expressing themselves, okay? Themselves, that's what the frontal lobe is, okay? Broca's area is only on that left side. It's expressive aphasia, and also how you can remember it, it's in the frontal lobe. B comes before W. W is back at the temporal lobe. So that's how you can distinguish between Broca's area and Wernicke's area. I'm going to continue to go over this because you'll have probably quite a few questions on your quizzes, midterm, and boards in both of your classes on this, okay? Making sure that you understand Broca's area is only on the left side, located in the frontal lobe. Okay. All right, so if a person has damage here, going to affect their personality, who they are, whether it's a CVA, we'll talk about traumatic brain injuries, it can really hurt how they think, okay, clear thinking, and then also their language expression. Only on the left side, if there's damage on the left side. Parietal lobe, what's there? What's right behind the central sulcus again? We have our afferent information come up and it gets processed where? In our post-central gyrus, which is the sensory cortex. Sensory information comes in and it gets processed there. Oh, it feels like a feather. I'm grabbing my cup. Okay, that's where it gets processed. Cortex is the processing. Parietal lobe, we want to think all about sensory in this lobe, and then also short-term attention and memory. Although we have that in pretty much all of our lobes, but you want to really link that there. If a person has damage here, they will have I'm really sorry, I'm very bad at pronouncing things, anomia. So A is without. They may have difficulty naming an object, okay? They may be able to hold an apple and they can't tell you by feeling it what it is. Their processing is not allowing them to tell you or understand what is that object. And we'll continue with that. So temporal lobe, what is temporal lobe? Really, what should you think about right away? Where is it close to?
Ears.
Ears, very good. So ears, so it's all about hearing. And then Wernicke's area is located here. You're receiving information in your ears. So if there's damage there, it's receptive aphasia, difficulty understanding what you're hearing. Receptive aphasia, auditory cortex is in here. So you hear something and you recognize, oh, that's a fire alarm, or my husband's saying something. I'm going to tune that out. No, just joking. But you can recognize what you're hearing, okay? Limbic systems here also long-term memory. So remember those hippocampus? Yeah, very good. All right. So I think we pretty much have that, okay? Understanding spoken words. And then our occipital lobe. And what should we think about here? Occipital vision. Very good. Okay. Vision. Very good. So anytime you have any question that says anything about vision and it's asking you where in the brain, it's the occipital lobe. It says, where is this being processed? Okay, occipital lobe. Processing what you're seeing, understanding what you're seeing, that's in that occipital lobe. The cortex is all about processing and understanding that information that's coming in. So anytime you see cortical cortex, it's all about processing. And then we all talked, everybody pretty much got that question right about the cerebellum. It's for our balance and coordination. We'll talk about that kind of separately in a little bit. All right, and then our diencephalon, again, is our thalamus, our hypothalamus. This is really what helps to regulate our brain. And these are the very deep structures. And there it's located there. Here, corpus callosum, white matter, help to communicate. My favorite portion of the brain, allows the brain to communicate. thalamus, hypothalamus, brainstem, MPM, right? And then the deeper structures, remember we had this on that other previous PowerPoint. This is just really that there's the decushions in the medulla where it crosses. And this is why if someone has a stroke on one side of their head, okay, let's say it's a left anterior cerebral stroke, artery stroke, they're going to have trouble with their right side, the right lower extremity problem. We'll talk about more of that specifically in a few. Brainstem, again, midbrain, pons, medulla. Remember the cranial nerves laying over this area. So if blood flow is trapped or blocked and they're lacking that, it's really going to have gross negative effects. And that's that locked-in syndrome that we briefly touched upon. So these deep portions of the brain, basal ganglia, we're going to get more into this when we talk about degenerative conditions like Parkinson's. And then our pons, again, just reiterating that where our cranial nerves are located. So locked-in syndrome, again, is when the person's completely paralyzed, they can't talk, they only can communicate through eye blinks. And then medulla oblongata is the decushions where the crossing of the tracks. So if there's damage there, there's going to be issues with the ability for it to cross. Cardiac control center, this is why it's so detrimental if an individual has damage here. Let's just look at the blood flow and then we're going to talk about the homunculus. So we're looking underneath the brain right now. This is actually the brain stem. So we have the brain, it's flipped upside down. These are the cerebellum under here, our olfactory bulbs. This thing here is called the circle of Willis. Okay, this is the blood flow to the brain. All right. So we have different arteries. This is going forward. So that's called the anterior cerebral artery. We have arteries coming out to the side that supply the parietal lobe and the temporal lobe. That's called the middle cerebral artery. And down here is our posterior cerebral arteries, supplying our posterior occipital lobe. And then we have our basilar and vertebral arteries. And that's really the most dangerous type of strokes. That's laying right over the brain stem and going down to the vertebrae. So I wanted to show you just this picture before we move. We're going to come back to this, but I want you to just digest that for a second. Lots of blood flow going to lots of different places. Now, the homunculus is this weird looking guy, okay? You take your entire body and you drape it over your brain. There's different areas of your brain devoted to this particular body part. And we talked about this. I remember I got all excited about the hand, how much of the brain is devoted there. It's a disproportionate amount of the brain is devoted to the face and the hands. This is why it's so important for our older adults to do those hand-eye coordination and use their hands and continue to write, play the piano, do all of those things because it keeps their brain active. So if this is their brain looking down at our brain, we have our central fissure, we have our central sulcus, our longitudinal fissure, I should say. Our central sulcus is right here. The pink is in the front. That's our premotor cortex located in our frontal lobe. The blue is our post-sensory cortex located in our parietal lobe. If we draped the human body over this, okay, it would look like this. The feet are actually down inside, okay, down inside that sulcus. And then the lower extremity comes out, and then it would be actually the hand and the face are on the outside. So this is the inside of the brain. So if you were to split this in half, you would see the feet are in here, the lower extremity, the genitals are down in there as well. And then the hand and the face are on the outside of the brain. What's over here? It's more the temporal lobe and the lateral side of the brain, okay? Outside of the brain is going to be the hand and the face. Thus, if we were lacking blood flow to the outside of the brain, the person would have issues in their face and their hand. But if they were lacking blood flow on the inside of their brain, they would probably present with lower extremity issues. We will continue to go over this. Coming back to the circle of Willis, we take this thing here and we take it off. I advise you print this slide out, draw this out so that you can understand it. I'm a big fan of saying and talking out loud so you can hear yourself, so you can register that and remember it, but also writing is going to help you because remember, a big part of your brain is devoted to your hand. So draw this out so that you can get a better understanding. So the anterior cerebral artery is going to come forward through the center of your forehead and supply your brain here. Okay, it's going to supply all in here. Your lower extremities, the brain part of your brain that's devoted to your lower extremities is right here. So if there's damage in your anterior cerebral artery, you're going to have leg deficits. The middle cerebral artery that's coming out here actually comes out to the side of your brain. In the very center, it's going to come out and it's going to come out through the temporal lobe. So if there's issue here, the person's probably going to have face or arm deficits because remember, the body's draped over and it goes the feet, the hands, and the face. Okay, everybody can see me, right, as I do that. And then the posterior cerebral artery supplies the occipital lobe. And then this is laying right over the brainstem.
I had a question about the anterior cerebral arteries. When studying like how to massage the face, we were noted about sinuses that we have through the bone, where that passes through.
Yeah, so it's going to supply that area of the brain. Obviously, as it leaves, because you can see these are really large here, as it leaves this area of the circle of Willis, which we can't palpate that, it's very deep, they're going to get smaller, smaller. So that's nothing that you should be afraid that you're going to be compressing those arteries as you do any massage here. Okay, but what you could think about is that is just really where they supply. All within the inside of the brain is more of the anterior cerebral artery, where the middle is more the outside of the brain. So then when you come back to looking at the homunculus, you can see the legs are more on the draped on the inside and the body is the rest of the body's on the out. If anybody has any questions at all, please put them through the chat or speak up. And if you don't want to have the whole class know what to, you just message me privately. That's not a big deal because this is a lot, okay? And I'm trying to slowly layer it in, and this is why I wanted you to look at it prior to class. So here, now blood flow leaves the heart, right? Blood leaves the heart through the aorta and comes up, goes through that subclavian artery and goes into those carotid arteries, okay? So carotid arteries come up the front and split. Let me back up. Blood flow can come from all different areas. So you're gonna see that blood flow comes from the heart and can supply all over. So blood flow is coming up here, splitting to the middle and anterior cerebral artery. Sorry, this is the middle cerebral artery here. Okay, so it's going to come up and it's going to split. It's going to come back to meet in that very center of that circle of Willis. The back, as the subclavian artery extends over, another portion that comes off of it is the vertebral artery supplying the back of the brain. So it comes up here and supplies the back of the brain. They meet together in the circle of Willis. So the vertebral artery, let me go back to this one. The vertebral arteries are coming up the back of the spine, and they're coming here and they're meeting here. The vertebral artery comes up and it can come up into the center of the brain, where the middle and anterior arteries are actually coming up and coming and to meet in this circle of Willis. So it's lots of blood flow. So that's why if there's an area damaged, they may still be able to have some blood flow to the area because of other arteries. Hopefully I didn't just lose you there. All right, so just know that when the blood's leaving the heart, it's going to come up through the aorta, go into the subclavian artery. It's going to split into the carotid and the vertebral artery to supply the anterior portion of the brain, which is the middle and anterior cerebral arteries. And if it's coming up from the posterior aspect, it's coming up through the vertebral artery. Thus why when we're doing cervical extension and exercises, the patient starts having visual issues or saying that they're not feeling right or having an onset of a headache, we're pinching off that artery, Okay, people who have rheumatoid arthritis are really at risk for that. So we always try to screen that before we do cervical mobilizations and mobility. We'll take a step back. If we're just looking at the brain, here we are. This is what's supplied from the posterior cerebral artery, middle cerebral artery, anterior cerebral artery. Okay, so we're looking from the side. If we turn this and we were looking dead on, this would be the anterior cerebral artery. It'll also be the lower extremities are hanging in there. As the homunculus folds over, this is going to be more the hands and the face out here in the middle cerebral artery. Everybody okay? So just another visual of the circle of Willis. Okay, so this is the circle. All right. So the blood flow can come up here. So if there's a blockage in, let's say, in the carotid artery, blood flow can still come up here, and it can start to try to supply that anterior cerebral artery if it's not going from the other aspect. Everybody getting that? Just might not be as efficient. Okay. There's another picture. So you can choose which picture makes the most sense to you. But middle cerebral arteries here, going in between this temporal lobe and the parietal lobe and on the outside of the brain. And there's another visual. So there's lots and lots of visuals of this for you so you can get a good understanding. This is the middle of the brain. The corpus callosum is set here. So we're going to talk about different strokes. Somebody has anterior cerebral artery stroke, they're going to have damage in that corpus callosum. How are they going to present? Difficulty with what? Bimanual tasks, communication of the hemispheres. Okay, I know this is a lot. And there's a visual of the actual blood vessels. Good. Let's talk just about the blood flow, and then we'll take a little breather so our brains can digest. And when we come back, we're going to do a breakout activity to paint a picture of what does a patient look like if they have a right anterior cerebral artery stroke versus left? Because they actually present very different versus a vertebrobasilar versus posterior, okay, versus left. But let's talk about blood flow real quick. So blood flow, let's say that we have our deoxygenated. Actually, does anybody feel comfortable talking about blood flow? I think it was last month that felt really good. You did well. Maybe you do again, or maybe we should call on somebody else. But let's talk about the flow of the blood through the body. You can pass, but if you want to give it a go, the best way we learn though is by doing, right?
All right, so blood flows coming from the perimena cava, I think, to the left ventricle, or sorry, left atrium, through the tricuspid valve to the left ventricle, through the pulmonary veins to the lung, that leads to the lungs to get oxygenated, then leads through the right atrium down to the mitral valve, to the tricuspid valve to the right ventricle, and then up the AV valve, right?
Okay, close.
And I probably mixed up the
Close.
terms.
You had your right and left mixed up.
Yeah, oh, yeah.
But I give you applause for just being on the spot, and I'm sorry I put you on the spot.
That's fine.
Yep, I think you did a pretty good job, but just had your right and left mixed up. What we have is our superior inferior vena cavas meeting at the right atrium. Okay, the atrium brings in deoxygenated blood. We try before we buy, so it goes through that tricuspid valve into our right ventricle, gets pumped out. What type of vessel leaves the heart? Arteries. So this is going to be the pulmonary arteries bring deoxygenated blood to the lungs. This is why a blood clot in the leg would end up in the lungs most likely. Okay, blood gets oxygen, comes back through the pulmonary vein, because veins return blood to the heart, okay, to the left atrium. That goes through the bicuspid valve, through the aorta, okay, semilunar valves to the aorta to supply the rest of the body. So if an individual has a blood clot, why do blood clots form in the heart? Because of turbulent blood flow, remember, with valves not working properly. If the blood's kind of circulating within itself, it's more likely to cause a blood clot here, okay? The blood clot then will go either out to the body, more than likely to the brain. Make sense to everybody? All right, good little refresher. Okay, good job for being on the spot. I advise you all to get used to saying that out loud. Maybe teach your family member, do something. Go through it, remember all of those structures because it's really critical and will help you when you're faced with a question and it's asking you what's so dangerous about a DVT versus where in the heart is most likely to form a clot that could go to a stroke or could go to the brain. Okay, returning to the blood flow to the brain. We have the anterior cerebral artery, the middle cerebral artery, the posterior cerebral artery, and then we have the striate arteries. You don't have to worry too much about those two, okay? They come off the anterior cerebral and the middle cerebral. The three primary ones are the anterior, middle, posterior. Most common strokes typically occur in the anterior middle cerebral artery, okay? Coming off that anterior, that carotid artery, okay? So this is showing the blood flow there. So when you're looking right on to the brain, the anterior cerebral artery blood flows here, middle's out here, and then we have our posterior down here. So with looking at the homunculus and laying that over the lower extremities, the feet, the genitalia, and the lower extremity is right here. The hand and the face are out here. That's why anterior supplies that, the lower extremity, middle is going to be more the upper extremity in the face. We have all these different syndromes that can occur based on where the area of the stroke is. Internal carotid artery syndrome, if the internal carotid artery, it divides into the anterior middle, that's really going to be very bad stroke because it's blocking both of these arteries, okay? So that's pretty significant. Vertebral basilar artery, that's going to be really bad as well because that is right on the brainstem area, okay? Same with the lacuna is low as well. We're going to break into breakout rooms and talk about the strokes per artery. You can find all that you need for your breakout room within this PowerPoint. I'm going to exit here for a second. When you're going over your artery, there's information here that you can pull from. You can pull from here. You can even paste your pictures in there if you want, but this is really for you for studying. And then you're going to go back up to the top to look for your medications. And then what I'm scrolling to is the very last slides of this PowerPoint talk about the differences between left and right hemispheric strokes. So if the stroke occurs on the left side, what was located on the left side of the brain? Broca's and Wernicke's area, okay? So those patients are going to present with aphasias, okay? Depending on the area that's involved. Where right hemisphere, Broca's and Wernicke's area are not located over there, these patients present very differently. Okay, so make sure that you're looking at these and you're including this in your summary, okay, and especially unilateral neglect. This will come up a lot and this might even be on your boards. Right middle cerebral artery, notorious for unilateral neglect, okay, which means they're forgetting that side even exists. And then there's some more here. There's a lot of information. Spend the time to really answer those questions thoroughly. Here's the document. Do you have a specific patient? They have a past medical history that probably puts them at risk for whatever type of stroke they've had. And what I want you to do is talk about a medication. Okay, it's asked you something specific about a medication, and I'll be looking for a specific medication. Then what's unique about this patient's presentation, or what deficits are they going to present with? And then this part, it sounds like it's redundant of this question, but this is really taking some of what might be in this presentation, their deficits, but what are they going to have difficulty performing? How are they going to present? Are they impulsive? Are they quiet? Are they very aware of their issues? Or are they not aware of it? Are they pushing towards their involved side? Okay, try to gather that information and really bulk this up so that it can really help you identify a specific type of presentation. I made a couple notes as you guys were typing. I didn't want to like hop in because a lot of you look like you're intensely into something, so I didn't want to interrupt. So that's why I typed to a couple of you about medications. I'll read the case and then I'll have you guys talk about it as I have the pictures up. It might be helpful. Group 1 has a 46-year-old female with a history of morbid obesity, uncontrolled hypertension, type 2 diabetes, and now hospitalized with status post ischemic right ACA stroke. Let's take it away. Group 1.
So for the medication that we put, we were going to put the anticoagulant medications, but you said that's for prevention. So we removed that one. What we have is the thrombolytic medications. So it converts plasminogen to plasmin and degrades the fibrin in blood clots. So then it helps degrade the blood clots that are wherever they are in the brain. And then so some of the examples are antiplates like TPA and urokinase. And from what I know, there's other 4 kinds. So there's total 5 kinds of them. But I'm not sure if the 4 kinds of that kind of medication is what they also give. So that's probably something we're going to have to look up ourselves. But for the deficits with this specific patient, most likely presents with contralateral sensory motor loss with lower extremity mostly affected. Right there. And then they tend to have, because lower extremities tend to be affected, so they usually have urinary incontinence and continence, aphasia, probably also dysphagia, I believe. We're not really sure about on that aspect. But
yes, let me just say real quick, most people who've had strokes, pretty much all of them across the board will have dysphagia.
And then for how the patient presents, they will have behavioral changes. So they would either completely change from who you thought they were, or because of that, they could also maybe revert from adult thinking to childlike thinking. So then sometimes speech patterns could also be affected. That can totally change, impaired speech pattern. And they will have weak muscle performances in their lower extremity. And they will have diminished sensation on their neck, as well as their trunk. And maybe also, of course, on the lower extremity that's affected. That's how we got so far.
Okay, no, that was good. The reason that she switched from an anticoagulant to thrombolytic, and the other group had it flip-flop too. So the question specifically that I asked this group was, what was the patient going to be given immediately to treat the ischemia? This is a blockage. So what we want to do is break up that clot to restore blood flow. Okay, that would be a thrombolytic, because break up the word, lytic means break up, thrombos clots. So that's why that would be the answer there. Thrombolytics are given to break up immediately to treat that clot. Okay, long term, that would be more anticoagulant to prevent the coagulation or formation of clots, or prevent a current clot from getting bigger.
Mm-hmm.
Most patients are given both. Okay, but there's different reasons for that. Now, they had a patient who had a right anterior cerebral artery stroke. This individual, Broca's and Wernicke's area is not going to be affected. This isn't going to affect their ability to, it's not going to cause aphasias, but it might cause dysphagia. Dysphagia is different than aphasia, and that's why I was like stumbling on my words, because they can easily be mistaken. Dysphagia is the inability to effectively swallow, and we'll talk about this more later, that you have to check the patient's chart to see what type of liquid they're on, because if you give a patient water and they're not supposed to have water, that patient could die. They could have aspiration pneumonia. So a lot of patients are given like thick and liquid honey consistency, nectar consistency. So you have to make sure that you're watching. And patients, they're going to be like, just give me some water. Can I have some water? They'll try to trick you. And you got to check it. Okay. The patients just want to drink water. It tastes disgusting to drink thick and liquid sometimes. That's what they want. Now, with anterior cerebral, look at here. Corpus callosum is involved. So the other group will talk about this too, but look at it. It's right in here. Okay, so this is the half section of the brain. The brain's cut in half. It's going to affect that corpus callosum. That will be a test question later on this mod, maybe on your final. But that ACA affects that corpus callosum, the communication. The other thing to note here is urinary incontinence. Where are the genitals? Right here. Okay, so that's how you can link it there. And then also mental confusion, amnesia, these patients' behavioral changes, what lobe is up here? Your personality, right? Frontal. Okay, starting to make sense? Right, so that is right cerebral. So you guys, very good. I would maybe just so that you don't get confused, I would delete that out of there so that you just don't confuse that. Just think right side. The other thing that you want to think about with the right sided, and this is all the way down at the bottom of the PowerPoint, is the patients with right sided strokes tend to be extremely impulsive. These are the patients that you say that you're going to go get a ball. Don't move, I'll be right back. And you turn around and they can barely walk and can barely move, but they try to get up out of their chair. These patients, they are very impulsive, not aware of their disability. And then what you want to highlight is lower extremity is much more affected than the upper. Not to say that they don't have upper extremity involvement, some may, but the lower extremity is much more involved. Now, we have the same artery involved, but let's see how it differs when the individual has it on the left side. So this group 2 has a 72-year-old male with CAD, hypertension, hyperlipidemia, and now is hospitalized with a ischemic left anterior cerebral artery stroke. So let's hear what you had to say.
Yeah, like Dr. Kiefer was saying, our patient was a 72-year-old male, the history of CAD, hypertension, hyperlipidemia, and now has a ischemic left ACA. We also had the discussion amongst ourselves whether a thrombolytic or an anticoagulant would be preferred in this case, and we ended up on the anticoagulant, especially because this patient needs to prevent long-term clotting ischemia. An anticoagulant like Coumadin or Eliquis, the one I was on, actually would work well for this patient. The type of deficits the patient would present with are things like urinary and mental impairment, especially like things like amnesia or confusion, behavioral changes, and obviously they have a left-sided ACA, so they're going to have sided paralysis. If someone else wants to continue from my group.
Yeah, what the patient may present would be apraxia, which is affecting the ability to imitate bimanual tasks, maybe damage to the corpus callosum. Abulia, which is, I don't know if I pronounced that properly, but lack of desire to carry out on action, delayed movement, slowness, and contralateral sensory and motor loss with the lower extremities affected more than the upper extremities.
Excellent. And I'm glad you termed it that way. Is when you're reading questions and it says the patient had a left ACA or a right MCA, it's always going to be contralateral loss, sensory and motor, contralateral. Oh, you have that ingrained in you. It's contralateral. Great job. Yeah, these patients are very aware of their limitations, okay, on the left. Okay, these individuals, I'm glad you included the bimanual task. There's slowness, delayed movement, but they're pretty aware of what's going on. Okay, these patients tend to be a little bit more quiet, and lower extremities definitely more involved in upper extremities. Okay, great job. All right, so that is our anterior cerebral artery. This is this area of the homunculus. Okay, this is the center of the brain. This is the center of the brain. Okay, frontal lobe, corpus callosum, all of that's involved. All right, moving on. I'm going to show you a couple of videos in a minute of the MCA strokes, just to give you a visual of this and help you. So let's have our patients. Our 81-year-old male had a history of CAD, hypertension, obesity, CHF, and is now in the hospital. Status post right middle cerebral artery stroke.
So our patient is an 81-year-old male with a history of CAD, hypertension, obesity, CHF. Patient is now in the hospital. Okay, so one of the medications that we have was Lasix.
It's LASIK. which is a dupe,
PTA.
excuse me, it's a loop diuretic. And basically it's a medication that gets rid of water and sodium from the body. And so it does this while reducing plasma volume, and it also lowers blood pressure. And the risks with the medication is dehydration, hypotension, electrolyte imbalance, and polyurias. And because of the diuretic, there's going to be frequent urination. And implications that as PTAs and PTs should pay attention to is patient positioning. We don't want to have them sit up right away, causing a drop in blood pressure. And also during exercise, we want to pay attention to not overwork them because of possible muscle cramps due to low electrolytes or weakness. And so we don't want to hurt them. And with that, on the medication side, I'll go ahead and pass the baton to our other teammates.
For the deficit, we wrote down like motor and sensory loss, unable to move like before, unable to feel sensation, and difficulty forming words or understanding speech. For the patient may present as like a facial droop. We were talking if it's going to affect either the right side or the left side, because I remember you mentioned that the facial nerve will only affect the same side.
For this, it will be
Contralateral.
contralateral.
Okay, so yeah, facial droop. We have like sensory ataxia on the left limb, hemisensory loss on the left side of the face and upper extremity. Just because if you look at the homunculus, it's for the middle cerebral side of the brain is pretty much just like the face and the hand. And the patient will also present like a left side hemi neglect, and they'll have difficulty in motor planning, so inability to perform tasks, even though they understand the instructions.
Okay, excellent job. So yes, mostly the hand and the face, exactly. Patient here is the right, so it's going to affect the left side. Now, how you can remember the unilateral neglect, so make sure you write that in here. They're going to present with unilateral neglect. This is really unique to the right side, okay? Let's take out Broca's Werke's area, because that's only if it's on the left side, okay? Let's take that out, because that's for the next stroke. For the patient that has a stroke on the right side, these individuals are going to present with left-sided impairments, okay? How I always remember unilateral neglect is most people are right hand dominant. It's really easy to forget about your left upper extremity when you don't use it that often, okay? And you don't have to walk on it, right? So it's unilateral neglect. Patients often forget or disown their left side, okay? So with these patients with treatment in mind, we're going to want to try to restore that midline, get them turning, get them paying attention, pick up that hand. Don't forget about your left hand. Okay, let's grab that left hand. Let's involve that left hand. Let's do bimanual tasks. Let's try to not forget about that side, because patients will forget about that side because it's easy to do that. Okay, so unilateral neglect, you're not going to hear somebody neglecting their lower extremity. They will, they can, but it's more likely in an upper extremity. Okay, so that's how you can key that into right middle cerebral artery. Okay, excellent job. Okay, again, this is the area. There's a list here, but remember, speech impairments is only going to be on the left. Okay, I'll add this to your PowerPoints. That way you can really identify left side. Okay, that's only area that those are located, and it says left hemisphere. Okay. Very good. I actually have a video. Let's see. It's the middle cerebral. Where did it go? There it is. Okay, this patient here, I know you can't hear it, so I'll talk over it. So look at his arm. That's his left arm. He had ischemic stroke 3 months ago, so they're trying to force this hand to push up through his involved lower extremity, but the right's much more involved, upper extremity. Look at foot position. Okay, he's got a lot of abnormal movement strategies. They're trying to really force weight bearing through that left lower extremity. And look at that, the spasticity in that right hand, it just clenches up. Okay, I can actually make this bigger, sorry. Okay, and they're performing sit to stands. There's 2 people there to help give that input. She's giving some input at the knee, at the waist. Okay, here, now look how well he progressed there, able to sit to stand. Again, look at the positioning of that left upper extremity. Now they're going to try to get some weight bearing through the upper extremity to help him with his walking. Okay. See, the left lower extremity is involved, but much more of that left upper. Okay, here, he definitely gait felt very safe. She's trying to keep him in extension, get that weight bearing, because he's offsetting his midline. Okay, trying to help with the placement of the foot. You can see it's quite stiff throughout the leg, that spasticity, okay? He doesn't have a whole lot of knee flexion. This is called a platform walker. But he's actually doing quite well. We got a 3rd person standby just to step in if needed. Okay, wheelchair follow. Quite a bit going into this rehab, right? But it's really neat to work in a subacute unit where you have the ability to have all these people assisting. Okay. Patient's able to walk across the whole room. But in this case, she's not really focusing like, hey, pick up your head, because that's not what they're focusing on right now. Patient can't really feel where his leg is. He's going to look down. Okay. Eventually, that's probably will work on, but not right now, not at the beginning of therapy. And there he picks up his head, takes a little break. And see how his body, his weight is really on that right side. So that's an image of somebody with a right middle cerebral artery stroke affecting the left side. Okay. Now our next group is group 4. I have a video for this one too. So this is a 66-year-old female with a history of coronary artery disease. Hypertension, 2-pack-a-day smoker, quite a bit there in her medical history that leads up to this ischemic left middle cerebral artery stroke. So how does this differ from the other stroke, group 4?
So for the medication, initially we are going for a thrombolytic, so we have to do the flip with Dr. Keever's advice. So it's more of an anticoagulant because thrombolytics break up current clots as opposed to 5 to 7 days it will take effect for the anticoagulants. Deficits that be present would be difficult with the right upper extremities, right facial involvements, right-sided weakness, aphasia, motor apraxia, dysphagia, and hemianopsia. Patients may present also with facial droop and trouble understanding or comprehending what the patients are being told by the physician.
Excellent, very good. Yeah, definitely aphasias, motor apraxia, dysphagia, so great job. And we'll talk about all these terms here in just a minute because you definitely will have to know them for next week. Again, MCA, so let's come back here. This patient now, this one, it has a 56-year-old male left middle cerebral artery stroke, so it's affecting his right side. So trying to help with weight shifting forward. Movement strategies, trying to so log roll, right? And back, but you gotta be careful of things that are hanging off patients, right? She almost stepped on his catheter. That might not feel so good for him. Okay. So especially when they're down the pant leg, sometimes that's hard to notice. So take note. Okay, she's having him support his non-involved arm. Okay, did you see that she had him get down onto his he's supporting his involved arm. He's on his non-involved side for rolling. Okay, because what are we worried about with that upper extremity? Dislocation, right? Especially in the early phases of rehab. Bridges are excellent. You're going to be going over this if you haven't already with Alex in rehab. Okay. Yeah. I know. There's no sound on my end. It cuts off. So I don't even have sound on my end. I know it would be nice to hear. But yeah, this individual, so it's definitely supporting that arm, always going back and look at there's two people with this individual. That's not always the case. So trying to really make sure that you're safe with the patient and having things set up. It's smaller because I can't see it. There's really not much more to that video, but yeah, this is called Physio U. However, in your ICE videos, you have a lot of nice videos and treatments. It just I didn't see anywhere where it had a specific case scenario, like giving you background, but that's okay. You still can get quite a bit from those videos, and you probably can gather where the stroke occurred based on the presentation. Would both videos be considered subacute clinics? Yes, definitely. I don't think that you would see it in outpatient, that many people able to do that. Although I did work in an outpatient neuro clinic that actually did look similar to this, but this looks more like a subacute unit or even an probably just a rehab unit. If the patient was in the hospital, they don't typically have these big, huge gyms in the hospital. You're typically working in the patient's room. There may be a small gym that has stairs because we have to see if the patient's safe to go home on stairs, but usually doesn't have a lot of this equipment, treadmills and things like that. That's typically not in an acute care type of gym. Okay, great question. Subacute, those of you who are going to subacute, you may see this. This is an inpatient bed. Could even be subacute care bed, have the same type of hospital beds, but these are all, yeah, so this is definitely subacute. Okay, so that's middle and anterior cerebral artery strokes. We're going to next talk about a patient who had a hemorrhagic posterior cerebral artery stroke. So right away, you're thinking vision, right? So let's hear from group 5 about your patient.
For this patient, 78-year-old female with history of CAD, hypertension, hyperlipidemia. Patient has a hemorrhage left posterior cerebral artery stroke. And yeah, so first one is just naming on medications for hypertension. And one we came up with, or that we looked up, was beta blockers. And hand it off to the next guy.
Yeah, as Dr. Kiefer had mentioned, at least with the posterior cerebral, it's going to be primarily sensory losses. That is what the patient's presenting with, primarily like through the ocular or occipital, sense, meaning that they likely will be unable to see or unable to recognize faces, and that degeneration will obviously go ahead and worsen depending on how intense the stroke was, but even issues with their memory. So if the temporal lobe was also involved with the incident, and then even through the midbrain and pons and the thalamus, spontaneous pains or overt preferences towards their non-involved side, indicating Pusher syndrome, which I think was more along the lines of that, those postural preferences that a lot of the other previous cases had. And then finally, we'll move on to the presentation with our third guy.
Yeah, so the patient, since their involvement in the left side, the stroke, so they present with a lot of right side weakness, aphasia, motor, apraxia, dysphagia, as well as difficulty communicating, difficulty processing information. They may present like being anxious and cautious, disorganized, and they're very aware of their impairments.
Excellent, very good. Now, great job. You guys included pretty much everything. Just to expand upon Pusher syndrome. Pusher syndrome is unique to posterior cerebral artery. Pusher syndrome means the person's actually pushing towards their involved side. So this leg and this arm can't hold them up, but their body's pushing them on top of that side. It's very hard to treat. It's very frustrating as a therapist to treat because you're trying to get the patient back to midline. The patient's midline's offset to their uninvolved side, they can bear that weight and they can handle it. For a leg that can't bear the weight and they can't feel, and they're pushing towards a complete side that can't feel them, it's really hard. Okay, and that's unique to posterior. So how I always remember it is P&P, pusher syndrome with posterior. Typically and hopefully the patient has this and they move right through this phase of recovery. It's typically a short period of time right after that they have the stroke that they have this, and usually they move on from it. Okay, or at least hopefully they move on from it. But it is, I can tell you, it's very tough. It's very hard. You're not typically treating that patient by yourself. Okay, but very good. Yeah, and vision and lots of pain. That they all suck to have, but this one really sucks. And then the next one even stinks even more because of its location. But I want to come back up here. You'll see lacunar infarcts. This just means that it's very deep. This is actually makes up about 15 to 25% of strokes because it occurs very deep in these very small arteries off the middle cerebral artery. So the patient may have like little TIAs or little like presentations of these. It's really common in these patients who have hypertension, diabetes, because of the lack of blood flow and hard blood flow to those little smaller areas. Okay. And the internal carotid, this is what I was talking about before. These are pretty massive strokes because it's blocking the blood flow where to both the ACA and the MCA. So the only way blood flow can get up here is if it goes up the vertebral artery, comes up, goes through the basilar artery, comes all the way up through the circle of Willis to supply the area of the brain. Very inefficient way to get blood flow to the front of the brain and the outside of the brain. Okay. Usually if people have strokes here, they probably are not living because that's a huge clot. Huge. Okay. All right. Let's move on to our last stroke that we're going to talk about, which is the vertebral basilar artery stroke. So remember, the vertebral artery comes up the back of the vertebrae, okay, to supply the base of the brainstem, the pons, and the cerebellum. The last patient of our cases is a 67-year-old male, type 2 diabetes, obese, hypertension, hyperlipidemia, CHF, COPD, and he now has a vertebral basilar artery stroke. So let's hear for the medication.
Yeah, we put for the medication to reduce muscle tone, so it would be an anti-spasmodic medication, like baclofen or Valium or Natrium. And then for the ischemic side, as you mentioned in the previous case, like thrombolytic medication, deficits the patient might experience. This happens in the vertebral basilar artery. So it would affect like their cerebellum and medulla, so like their balance or respiration. And then the vertebral vascular artery syndrome, ataxia, mild hypotonia, ipsilateral, seeing impairments, and the 5Ds. And then if somebody want to take over for the presentation.
Yeah, it looks like the patient may present with loss of vision in one or both of the eyes, even double vision, vertigo, numbness or tingling, nausea and vomiting, slurred speech, once again, loss of coordination or balance, and also having trouble swallowing.
Excellent. All right, very good. So this one you're going to think is like really the most severe because it has these 5Ds. The patient's going to present with really a dysphagia, so difficulty swallowing is dysphagia. Dysarthria, what is that?
Slurred speech. Or
Kind of slurred speech, but also more like your ability to project your voice, okay? Phonication, all right? These two are different. This one's swallowing. This one's about your ability to actually speak and get the words out. Diplopia, so that's that double vision, dizziness, drop attacks. Remember, if you see 5Ds anywhere, you're linking it right to the vertebral basilar artery stroke or basilar artery strokes, okay? There will be questions on that. It may not have every single D in there, but if you see a bunch of these Ds, you gotta be thinking vertebral basilar artery, okay? All other arteries are going to have contralateral signs. Sometimes this one has ipsilateral signs. Okay, ipsilateral, but everything else pretty much all strokes that other strokes that we treat is going to be contralateral.
Not all 5Ds have to be present.
No.
Only a piece. Okay.
Yeah, so if the patient just presents with dizziness, dysphagia, and drop attacks, then you're thinking that it's got to be there. Yeah, just the majority of them. So if you don't see every single one in a question, you're still going to be gravitating towards there. Symptoms of cranial nerve disorders. This is, again, remember, this is going to be the same size. So cranial nerves are peripheral nerves, okay? So it's, if there's cranial nerve disorders, it's going to be damage to that nerve on that same side. Picking up where we left off, so basilar artery strokes, this is that locked in syndrome. I keep meaning to remove this picture because this gives a false presentation of locked-in syndrome. Patient's not able to use a communication device. They can't move their hands at all. These are really great for patients who have aphasias or have had strokes or have any other kind of neurological disorder where they have difficulty with communications, but typically not used with locked-in syndrome. Locked-in syndrome, these patients have complete paralysis of their limbs, diaphragm, and their face. Okay, they only can perform eye movement, and that's usually how they start to communicate. Pretty sad. So during a PT evaluation, what we do as evaluating therapists is we come in and we assess the consciousness of an individual. You are going to do this also. You always want to know if your patient's alert oriented ×4, okay, the situation as well. This is something, a good habit to get into with pretty much all of your patients, especially if you're working in subacute or home care, getting this, especially with older patients or aging patients, I should say. Also figuring out, okay, what is their emotional status? Do we need maybe it's to refer in or refer this patient to another healthcare professional? Because remember, again, we can't solve it all, even though we want to help the patient in all different ways. But we're not the best to address depression. We're not the best to address dysphagia or dysphagia. The patient needs a speech therapist. Okay, so recognizing this communication and language difficulties. Sometimes we do co-treatments, which are really helpful between OTs, PTs, even speech therapists with PTs, and then determining, assessing their pain in the location. Also, skin assessment. Every patient that we assess, we should be looking at their skin integrity, seeing if they have any areas of deep tissue injuries, which would be present like non-blanchable areas, and sensory, checking out all of their joint integrity, seeing their active and passive movement along with their assessing their muscle tone, checking for any abnormal reflexes, their motor control and coordination, and then obviously strength, power, and endurance. Now, if somebody has tone hypertonicity, presents like the patient's extremely strong, you cannot do an MMT test of somebody who has hypertonia because it doesn't give a true reflection of the patient strength. So typically how we assess strength is through their functional mobility. Can they perform a sit to stand on their own? How do they ambulate? How is their push up? Are they able to do a heel raise? The things that are functional, can they lift something up with their upper extremities? Other things that we look at is how is their wheelchair? How is their wheelchair fitting them? Their management of it, is it appropriate wheelchair? Orthotics that they're wearing, do they fit? Do they work? Okay, and these are things that you're going to look at too. Maybe the patient was evaluated a week ago and for whatever reason, they hadn't seen a therapist in over a week. Sometimes in home care that happens. There's a lot of appointments that occur. A lot can change. And during evaluations, there's a lot to try to get done in a short amount of time. So some things may be overlooked. Hopefully not, but these are things that you should keep in mind too when you're treating a patient and bring it up to the supervising PT to either make adjustments or put in requests. But when it comes to impairments, you're going to need to know all the highlighted terms for next week's quiz and going forward. Okay. We'll discuss a lot of this during our week that we cover traumatic brain injury, which is week 5. Because this has a lot to do with injury to the brain, right? Different lobes of the brain, depending on where that trauma occurred. Okay. So a lot of overlap here. So you're going to continue to have these types of terms continue throughout the rest of this course. and throughout the rest of your career. So attention, the patient's ability to pay attention to what you're doing and not other things that are occurring within the room. Do they have your undivided attention? Are they able to split their attention? Or do you need to get them into a private setting, a quiet setting, so that they can focus? And we'll talk more about different types of attention in traumatic brain injury week. Memory. Okay, memory can be affected in all lobes of the brain, but you're really going to think about short-term being in the parietal lobe, long-term being in that temporal lobe. Okay, patients sometimes will fill in the gaps with inappropriate words. They may make up stories, and this is something that you need to keep in mind, but maybe also educate family members. If the patient's in a subacute unit and they say that a guy came in and danced at the end of their bed in the middle of the night, and a family member hears this, they might think, or that they got hit. These are real stories that patients say, and that never happened. Okay, but sometimes patients make up these things. So it's something that we may want to educate the family ahead of time, that you may hear your loved one say things that are not true. Now, that's hard because you hear of bad stories happening in subacute units. It is something to be aware of, and making sure that you're educating the family properly. Another issue that sometimes happens quite often is a patient may get really stuck on a thought or a repetitive word. It can be frustrating. So it takes a lot of patience to work with patients who have neurological conditions, but imagine how frustrated that individual is. Okay, so anytime that you might start to think you might be losing your patients, take a deep breath and put yourself in their shoes. They don't want to be having this issue. So if they're stuck on the door being closed, can you shut the door? Okay, if it's easy as shutting a door, the patient can move on from it, then shut that door. Okay, but always trying to get the patients back focused to what the topic is or whatever you're working on with these individuals. Okay, and we'll have some videos of these types of behaviors, more so when we cover traumatic brain injury. There's also assessment tools that can be used by all different types of healthcare professionals, but many mental status exam is a very common one that can give you a status of where they are mentally. Executive functionings can definitely be an issue. So a patient might, like I said, they might try to stand up even though they don't have the ability to stand up. Their body might not have that judgment. They might start to move their upper extremities and their legs aren't even moving. So that the motor planning is disorganized. Really trying to have a plan and having purposeful actions and really affecting an effective performance of an activity is really our goal, with doing not only that function, but having the brain function properly with these types of activities. Patients sometimes lack the abstract thinking. So trying to work on maybe parts of a whole task. So a lot of what we talked about last mod in 310 with dividing up activities really plays into these individuals, okay, with that cognitive phase, associative phase, that autonomous stage, okay. Many patients may be apathetic, they may be depressed or anxious, so make sure you have a grasp on what their mental status is. Patients sometimes have outbursts that don't exactly match their mood. Okay, patients may start crying, even though they might have started off laughing at something that was really funny, and then all of a sudden start having this cry. So it's really having a hard time with emotional life. Other things to think about is speech and language impairments. Pretty much most patients who've had a stroke will have some sort of either communication issue or a swallowing issue or both. Okay, so aphasia is without some sort of communication. So where is receptive aphasia? Where's the damage if the person has receptive aphasia? Your choices are Broca's or Wernicke's. The Wernicke's, how you can remember that is the W is behind the B. The W is by the ear. You hear the information, you're receiving the information, okay? You have a hard time understanding what is being told you. So if you have a patient who's receptive aphasia, if you tell them to stand up from their chair, they're not going to hear you. So what might you do to have them stand up from the chair? You want the patient to stand up. They can't understand you saying stand up. Tactile or visual cues, exactly, very good. When you have a patient in your practical that has receptive aphasia, you're gonna be using a lot of your body mechanics and body ability in your hands to really help these individuals. Now, expressive aphasia, patient can't tell you, they can't even write down what they want to tell you. This is super frustrating, okay? This is Broca's area, more on the frontal lobe, okay? They can't express themselves verbally. Okay, but maybe they can point to a picture. Okay, this is where it's nice when we can work with speech therapists on trying to have clear communication, because nothing's worse than a patient who's really frustrated that they can't get out something, and then we're trying to work on a functional mobility activity. Okay, so trying to make sure that we can clearly communicate or communicate to our best ability with our patient. Dysarthria, again, this is articulation. Sometimes this has to do with respiration, okay? Patient can't fully speak because that's a lot of work of the lungs and trying to get that phonication or that resonance of their voice, okay? Dysphagia, so again, it's about half of patients who have strokes have this problem. This is why you need to ask what their ability for liquids is. NPO means nothing by mouth. Why they abbreviated it this way is annoying. It should say nothing by mouth, right? NBM or something, but it's NPO, precautions. You have to see what is it. Do they have a GI tube? And if they do, where are you putting that gait belt, okay? Things to keep in mind. Patients may have oxygen tubes, GI tubes, and catheter all at the same time. How are you going to manage that and perform your functional mobility? A lot of planning. And then sensory, astereognosis. You're touching an object without visually seeing it, and you don't know what it is. You're holding a baseball or an apple, and you feel it, but you can't process it. And you don't know what it is. So where would that issue be in the brain? What core? Sensory, parietal. Very good. Sensory parietal, because you're touching it. If you have the inability, if you're looking at it and you can't recognize it, then that's occipital. If you're tactile and your tactile information is not being processed, that's your parietal, more importantly, your sensory cortex in that parietal lobe, right behind the central sulcus. Okay. And a lot of patients have a lot of pain who have had strokes. Okay, a lot of different areas, headaches, different things like that. And when a patient has a stroke, they're at a high risk for a second stroke. Monitoring blood pressure, monitoring these symptoms, making sure that they're not at risk for or having symptoms of this having another stroke. Okay, where's their vision? Heavy anopsia, so that's being blind, and hemi is 1. A is without. Okay, so they're without half of their visual field. Perception of impairments, and a couple other highlighted terms. A, again, is without, so they're denying or neglecting that they have unawareness of their paralysis, okay? So this A, okay? And then the other one, I'm not even gonna try to pronounce this one, maybe I will try to pronounce it, asomatoagnosia. This is lack of awareness of one's body structure, relationship to their environment. Okay, so the left and right, they're lacking that midline. These are all things you're going to go over again tomorrow. Okay, but make sure that you're looking at, there's different types of agnosia: visual, auditory, tactile. Auditory, you hear an ambulance and you don't know it's an ambulance. You don't know to get out of the road. Okay, astereognosis is that tactile and you don't know what you're feeling. And then your visual is you're looking at someone and you don't know who they are or something. Okay, muscle performance, we talked about this last week, but now more defined with stroke recovery. So a patient first has a stroke, they're actually flaccid right away. Okay. We hope that patients move through these stages and get back to their typical coordination and appropriate responses and typical movement. Disappearance of spasticity. So they go through these stages here. So start off flaccid, and then they move into synergistic patterns, okay? Voluntary synergistic patterns. You'll talk more about synergies this week. And then they may have difficulty learning movement combinations, and then they can have restored movement. So that's the progression through the stages. Some other words here that will constantly go over the next few weeks. Plegia means absence of strength. Paresis is weakness. They sometimes are used interchangeably, but that's really what it means, okay? One side is not very strong. Now, paraplegia is just the lower extremities. That's typically in what type of diagnosis? Both legs are involved. Spinal cord injury, not stroke. Unless they've had a stroke on both sides. But that paraplegia is both lower extremities. That can also be seen in patients who have spina bifida. Okay. Quadriplegia, tetraplegia is basically the whole body. Diplegia, also diplegia is usually both lower extremities. So diplegia is typically interchanged with paraplegia. Okay, and that's it. Those are the terms. We'll talk more about those. Now, we talked all about this, so I'm going to scoop past these. Fasciculations, remember, this is related to lower motor neuron lesions. And then our movement here. Voluntary movement, really, can the person perform an activity at the right pace, right sequence, right rhythm, okay, and perform it effectively? After a stroke, probably not. Okay, so patients typically who have movement issues typically have issues with their motor cortex. What lobe? Frontal. Okay, their premotor cortex. They typically have problems with the basal ganglia. We'll talk about Parkinson's. Cerebellum. Those patients have a hard time putting their finger to their nose. They overshoot, they undershoot, and they have difficulty with timing, sequencing. Okay. Abnormal synergies. Coactivation. You're going to talk a lot more about these type of things tomorrow, so that's why I'm going to skip back. But synergies are definitely something that are abnormal movement patterns. Okay, the patient has spasticity in their upper extremity. Typically, it's in a flexion synergy. Okay, so you can put yourself in this position. You're going to actually elevate and retract your scapula. You're going to eviduct and externally rotate your shoulder. You're going to flex your elbow, flex your wrist, flex your fingers. This is the position the patient's typically stuck in. Now, to what extent, it depends. But you saw that individual, when he was sitting, his arm was relaxed. As soon as he started to go move from sit to stand, you saw his hand plunge up. And then as he got into standing, his arm went into that position automatically. Okay. Typically, flexion is the synergy for the upper extremity, okay? And extension is the more typical one in the lower extremity. So patients typically are in this extended hip extension, abducted, internally rotated, plantar flex, and toed flex position. That's what he was presenting with in standing and was interrupting his walking, right? He didn't have any flexion. They're trying to get him into flexion and moving him into dorsiflexion. There's a couple of videos you can watch on your own here of these patterns, but this is typically what the limb likes to move in or move through. So it goes from an extension synergy and might go into a flexion synergy of the lower extremity. Dystonia is, remember, this is involuntary movement and it's dysfunctional movement. This is writhing and twisting movement, okay? Not commonly seen with strokes. And then these are just some other terminology that you'll have to be comfortable with. Dysdiadokinesia. This is, I'll test my patients. I'll say supinate one hand or put one palm up, one palm down. Okay, go back and forth, alternate back and forth. Can they do it? Okay, yeah, and that's it. I think that's pretty much it. And then this is just a summary. So in general, patients who have right-sided strokes, they're going to really present with a lot of impulsive behaviors. These patients are the ones that are going to laugh and then cry, or cry and then laugh, and they're going to mix up all their emotions. Where left hemispheric CVAs, these patients present very aware of their limitations, okay, typically. And these are this is the side where they have the aphasias, if they are present. Okay, so and how I remember this distinction here is if this left side is what holds those Broca's and Wernicke's area, the patient has difficulty with communication, they're going to tend to be more quiet. Those patients are much more aware. Where right-sided, these are the patients that just are, you literally cannot leave them alone. You cannot tell them, oh, I'll be right back. I'm gonna go get a ball, because they're gonna be like, oh, I wanted to get up and go to the bathroom. You can't stand. Okay, so that's the difference there. Here's some more behavioral differences. Wow, a lot of information, right? So that's why I really wanted you to look over all of the anatomy, the homunculus and the blood flows. It's okay if you're a little confused right now, because this is a lot of information. So take your time digesting it and going over it. And then if you need to meet with me, that's fine, okay? Because I know it's a lot. It's a lot. We are going to finish up with the Kahoot. Unless anyone has questions that wants to pop it through the chat right now. But my advice for studying would be make your own chart. So my advice for studying is really maybe make like on one paper so you can see it all together and do what's unique about that patient has a right CVA versus left CVA versus MCA, ACA, or whatever. So divide it up and then try to pick out what does that stand on information. Okay, I know it's a lot, but that's probably the best way to do it. Yeah, neuro is cool. What's neat is you're going to do all those interventions you learned last mod, but you're going to apply them. You're going to apply it to a patient that has a neurological condition. So there's just an extra layer of awareness. So we did bridges last mod. You're still going to try to perform a bridge the way you did. There might be some other tactile cues you're going to give the individual to really try to kick on their glutes or assist that leg that doesn't really want to turn on. Okay, maybe it's a tapping technique, maybe it's a grounding technique. There's just some really cool things. And last mod we talked about mobilizations, joint mobs, but actually with joint mobilizations, we can also do compression, right? Get that patient's brain to pay attention to that joint. Okay, maybe we're pushing in and down, approximating that joint to get that brain to pay attention to it. So there's really some cool stuff that we can do with these types of interventions. So all our warning signs of stroke, except you wouldn't see a droop on both sides, right? Stroke doesn't affect both sides, it's gonna affect one side. Okay, slurred speech, absolutely. Sudden headache, that's a very classic sign. It's the worst headache of their life, remember? And then the eyes, it could be one or both, but it's not gonna be droops on both sides of the face. It's not gonna affect both sides. The corpus callosum inside the brain, what's right here, what artery. X-ray is not something we talked about today, right? X-rays are going to show bone, they're not going to show blood. Thrombolytics are appropriate medication and manage hemorrhagic strokes. What is happening with a hemorrhagic stroke? Bleeding. Do you want to give something that possibly could prevent blood clots to somebody who's already bleeding? No. The treatment, there's no medical management for hemorrhagic stroke. They have to go, if the body doesn't clot on its own, then the patient is going to end up having to have surgery. Okay, so make sure with these types of neuro questions, you're really reading what the question's asking you. And I know this is a Kahoot, so it's quick, but just something to keep in mind. Cognitive functioning, most you got it, very good. It's going to be that frontal lobe personality. Vision's going to be the occipital. Damage here causes contralateral sensory and motor loss primarily in the face and upper extremity. That means it's happening out here. What supplies out here? Middle cerebral artery. If this is damage here caused contralateral sensory motor loss primarily in the lower extremity, then it would be the ACE. So this is the same type of question, just worded a little different. So MCA causes contralateral hemiplegia. Guess what? So does the ACA. Okay, basilar, okay? Basilar is the one that lays right over the brainstem. Okay? The carotid artery is what supplies the ACA and the MCA. That's not locked-in syndrome. Locked-in syndrome is when there's damage to the brainstem itself. Question, right? First, you have to break up the question. What does the parietal lobe primarily do? Sensory input, right? Integumentary, skin sensory input. That would be hypoesthesia. Okay. Expressive aphasia, this is ability to express yourself. This would be more Broca's area, frontal lobe. Balance deficits would be cerebellum. And burning pain. What do you think about burning pain? This is more like deep thalamic. A little tricky. So what's easy to forget about? Your left upper extremity would end up being the right side of the brain. So then you're between right ACA and MCA. The MCA is what does the face and the upper extremity. ACA does the lower extremities. It's got to be right MCA. That will return on midterms and finals. This is the vertebral basilar artery stroke. 5 Ds. Okay, make sure you know that for the quiz. A is without stereognosis. Aphasia is speaking. Okay, aphasias have to do with speaking or understanding speech communication. So then you could automatically cross off fasciculations. There's nothing in this that's giving you any hint to this. Okay, A is at least without that. So you could be between those two. Fasciculation, remember that's the little muscle twitching and lower motor neuron lesions, and hemianopsia is half, without is A, and that has to do with the eyes. So you're without half your visual field.